Okay, Kayla's not here. Charlene Nelson?
Here.
Lynn Telford?
Here.
Arlette Preston? Oh, there she's back. Hi, Arlette.
Here.
Robin Nelson?
Here.
Dwayne Breitling?
Here.
And Bernie Dardis. So we have 2 absent.
Okay, thank you, Lori. Desi, any announcements?
So the only thing I was going to mention was that City Commission this past Monday did reappoint Chelsea and Lynn again to the Board of Health. So I just want to thank those 2 again for their continued service for us. And the other thing was when we were having the surveys about the day that we were going to do Board of Health, we did land on a Friday again, because that seemed to be the most favorable day for most of the members. And so we will just do our best with staff to make sure we have people there that are needed for those days. So, and then we'll be approving the schedule later in the agenda. So that was all I had for today, other than everybody, hopefully after today, have very happy holidays, and hopefully people will be able to enjoy gathering safely with family as they can. Thanks.
Okay, thanks, Desi. I think Lori sent out the minutes from last meeting back in October already. It's December. So I'll entertain a motion to approve the minutes from October 15th.
So moved. Robin Nelson.
Thank you, Robin.
I can second. This is Lynn Telford.
Thank you, Lynn. All right. All those in favor signify by aye.
Aye.
Any opposed? Okay. All right. Minutes are approved. Next on the agenda is Dr. Hogan. Very excited to have you and to hear more about your position and how we can work together in the future. So I'll hand it over. I think you have maybe some slides as well. So nice to meet you.
Oh, well, thank you so kindly. First and foremost, I didn't put together a slide, but I do, Jeff, I have a little introduction of who I am and, and what I've done and so forth. And obviously, my name is Dr. Terry Hogan. I retired in Chicago after 26 years of being in higher ed, teaching courses in public policy and sociology, while still consulting, in the various cities for the last 20 years or so. And when I was asked to come here to the city of Fargo and so forth, I paused to a certain degree because I wanted to understand, what were some of the difficulties that Fargo was having. So it's just to get away from that. What I do is diversity, equity, and inclusion work, which is DEI. And oftentimes when people, as a matter of fact, quite a few individuals have asked me here in the city of Fargo, what is DEI, better known as diversity, equity, and inclusion? And oftentimes I try to make it very simple because that could be complex terminology when you are asking what is diversity, equity, and inclusion. So just to give you a brief, limited view of what diversity is. Diversity is the lay terminology of differences or variations. Equity is the lay terminology of equal or fairness or being impartial. Inclusion is basically saying, regardless of who you are, where you come from, your race, your ethnic background, your gender, your religion, your ability, or what have you. All of that is saying, you know what? We can have a seat at the table to do what we need to do to have our company, our organization, our public sector institutions to thrive. Now, what is it that we do as DEIs? DEI is a very, very broad term. And oftentimes when I say broad, it gets to the point is that we can be facilitators one day. We can be arbitrators another day. We can build strategies. We can initiate initiatives. But at the end of the day, it is all about best practices. What can you do to make the institution, the organization, the city run well? And this is what I'm here for. Now, what is my job here in the city of Fargo? And my job here is basically to conduct a community-wide assessment on diversity, equity, and inclusion within this entire community. For example, I will provide coaching and support for the city departments. I would use innovative tools. I would use various strategies, if you will, in order to get that done. I am responsible, by and large, for community education. What I'm noticing here in the city of Fargo is that we have is what you call new Americans. And that's the terminology. As a matter of fact, I had never heard that terminology before, new Americans. And being is that I'm working with a tremendous amount of new Americans, I am educating a tremendous amount of new Americans here in the city of Fargo. Why? Because most of these guys want businesses. Most of these guys want to seek the educational opportunities. Most of these guys want to know who their city officials are. All of these things is that I am doing as a layperson to have these guys to understand what goes on in and around them. So at the end of the day, my job is a continuous building process of relationships. It is a continuous building process of partnerships. It is a continuous building process of working with all the stakeholders and so forth, because we do want Fargo to be the best that it can be in every way. So with that being said, I normally go out of the scope of what I've been trained to do, but that is because I have municipal experience, you see. And with that being said, I can be doing any catalyst of a job amenities at any day and any time. And this is just who I am and what I do here in the city of Fargo.
Excellent. Thanks, Dr. Hogan.
If you have any questions, I'm willing to.
Any questions?
I don't necessarily have a question, but I'm really excited to have you here and excited to see what an impact you can make on the city and how the board can support in any way. But welcome, and we're glad to have you.
Oh, well, thank you so much. One thing about it is I must also mention is that DEI work is slow and methodical. Nothing happens overnight. And oftentimes it is hard to get constituents and citizens and people to understand nothing happens overnight. And depending on what culture that I'm going into or my team is going into, whatnot, we want to make sure is that the educational structure is there. I am an educator first. And that's the first thing. I am an educator first. And once you educate the public and they know, where your terms are and what you are planning on doing, then they feel they feel as if they're not being challenged a hell of a lot. Because right now, and when I first came here, people felt challenged as though this guy's coming in to do this guy's coming in to do race. And no, it's more than all of that jazz, if you will. It's about me coming in, more so bringing people together, bringing businesses together, and we are all just working with each other, doing what we need to do to make this entire fabric work together.
Hey, Dr. Hogan, this is Desi.
Yes, Desi.
Do you want to share a little bit about just some of the work you've done with city employees, just so the group is kind of aware of that too, and the types of surveys or assessments you've done with them?
Absolutely. One of the things I
just want to let everybody know Kayla Nelson is here. I am not able to get my computer working.
Thanks, Kayla.
Oh, hi, Kayla. Okay, one of the things is that I am doing in the process is that we are doing is what you call, well, I am doing, is what you call an environmental scan. And this environmental scan I am doing throughout the process of City Hall. I am working internally and externally. As a matter of fact, I've been over at the Public Health Department, and I see some of you guys that I've worked with, and thank you for doing so. But the environmental scan is basically is that we have is what you call a SWOT analysis. And a SWOT analysis is basically strength, weaknesses, opportunities, and threats. Okay, strength, weaknesses, opportunities, and threats. So what does that mean? That means, in fact, upon me doing the environmental scan, this is what I'm looking for. Are there weaknesses in your departments? What is the strong assessments of your department? What opportunities are in your department? And if in fact, if there is some dysfunction in your department, because each institution and each organization is totally different from a municipal standpoint. As an example, I came from a ward governmental standpoint, whereas you have a ward system. And within that ward system, you have either number one, a city councils, or you have number two, aldermen, you see? So the thing is that, when I'm doing this environmental scan within a population, of 126 plus or more so within the state, this local process, I am trying to see or assess what is Desi doing? Is she doing a good job? Because what her employees tell me are the themes that I can put forth. And if there's weaknesses, I can come back and say, hey, Desi, this is what we need to do. And this is what we can do. And the end result will be right here. So with that being said, I have worked right now with all the directors of City Hall. I've looked at staff within City Hall. I've gone outside and worked with Desi and some of the other people outside and so forth. And right now what I'm doing, I have a stack like that. So I'm reading the stacks, and it's just me, of course, so it's going to be slow and methodical, but I am reading the qualitative method of all of the interviews that I've done, and I'm putting together themes. And these themes oftentimes will tell me as a researcher what kind of things that are going on in your department. What are the strengths? What are the weaknesses? What are the opportunities? And what are the threats? Because sometimes we as managers, we don't see the other side. We're trying to get things done more so from the administrative standpoint. So I'm looking into all of that. Now, with that being said, going into 2022, we're going to have is what you call a climate assessment, which teeters off of the environmental scan. A climate assessment is where is that I am going to bring in a team. These are people who specializes in every formality of what they need to do. And these teams are going to be doing interviews, surveys, focus groups, whatever that needs to be done in order to get to the, as I say, meat and bread of the threat, or the meat and bread of the strength, or the meat and bread of the weaknesses, and so on, to make Fargo and your organization via your institution much better. So, there is a lot of things that I am seeking to do in the year of 2022. And as I've, just told everybody that have interviewed me, just wait and see what happens, but it's going to be a good thing.
Excellent. Other questions?
Don't be afraid. Please ask.
Is there anything that's surprised you coming?
What?
Coming here.
Well, yeah, yeah. More so, some of the people. Although they did not know, in fact, that, or what a DEI, better known as diversity, equity, and inclusion, mean. I was expecting somewhat to get a tremendous amount of pushback. And if there's been pushback, it hasn't been in my face. I'll be very clear. You know, I come from a big city. I was born in a small city. So I've seen a lot of things, you know, in my 20 plus years of doing this line of work, because I've visited a tremendous amount of municipalities, and also coming to a very conservative state as North Dakota. And with that being said, you know, being as I'm from Chicago, they probably thought I was liberal or Democrat or this, that, or the other. And, you know, and I leaned back on my academic career, and, you know, what I would tell my students all the time, as a matter of fact, I was asked my students all the time, well, do you think Dr. Hogan is Republican or conservative? And the first thing, you know, they would say, in fact, is that I'm Democrat. And I would say, why? Because I'm Black. And the reason why I would say that, because there was a rationale of Blackness. We all lean liberal. But at the same time, too, the literature suggested that as you become more and more educated, you lean more outside of the realms of being a conservative and or a Republican. And so I would tell folks all the time, I am a very independent voter. I vote both ways. So if it fits my agenda, I am good with that. So in answer to your question, is by and large, is that, you know, I thought is that I was going to have a tremendous amount of pushback. And by and large, if people basically, you know, if they are pushing back, it's never in my face, you know. And so, you know, when I go out into public, it's often said to me, good job. We're glad to have you here, you know, and that is encouraging. And that is encouraging. But at the same time, too, I know, in fact, I won't be liked by everybody. And that's okay. You know, that's how the world is. But the bottom line, I'm here to get the people's work done. You know, I'm going to do what I need to do for the city of Fargo and move forward.
All right. Well, to echo Lynn's comments, we're certainly happy to have you on board.
Thank you.
So, excellent.
Thank you.
All right.
Chelsea, if I could ask a question.
Sure.
I apologize. I had to step away for a bit. Trouble with doing these virtual meetings when the doorbell rings. I got called away a little bit. So I apologize if you covered this, Dr. Hogan, but can you comment on how the Board of Health might help support or provide you with resources in any way, information, whatever, in regards to your work?
Well, as it stands, in 2022, let me just back up. Right now, it appears, and I'll use that terminology, it appears, is that I have tremendous support, and tremendous support from the board, tremendous support from the administration. I have made my minimum demands on what I need in order to get things done to the administration that I work with. And they have, by and large, given me some, it appears, is that they want to work with me in 2022 by giving me what I need in order to get some of the things done that I want to get done. Now, at this point, we haven't talked about budgets and so forth, but obviously we're going to have to talk about budgets, and the reason why, because Desi, for example, I am going to, and I'm going back to my team that I had in the city of Chicago. I am going to have a person that deals and works with healthcare affairs, meaning working directly with you and what you do in the health department. I am going to have a person that is a program manager for immigration. I am going to, these are things that I normally had when I was, you know, in the city. So these people, not as if they don't come cheap, but, you know, you want to take care of them because they have the experience and the education. So with that being said, it appears is that, you know, everyone seems to be on board. I don't want them to take this work for granted because, as I've said, we are in the process of making Fargo the best that it can be in every way. It is a slow and methodical process, but can it get done? Yes. So this is where we are at this point, Commissioner.
So, ouch, whatever that was. I heard some scratching. I don't know if anybody else did, but if I could reiterate also that it's wonderful to hear that you talk about some connections on the healthcare side, understanding that COVID has hit communities of color probably more hard than other communities.
Absolutely.
And the ability to reach out for vaccinations, anything like that I think we could connect on would be really helpful. And I don't mean to be speaking for Desi here or Dr. Newman, but from the Board of Health perspective, having that kind of connection, especially in regards to public health, that would be really good.
You know, and just to echo that is that the person that I will be bringing on, hopefully, this person has all kind of tools to use in order to help Desi and individuals to encourage, if I may use that, people to get vaccinated, you know, and so forth. Because with that being said, you know, I try to put people in places of their specialty and what they can do. And I believe, in fact, this is why my team have been very, very successful. As a matter of fact, you know, we broke up when I came to Fargo. You know, they all were doing other things. But eventually, you know, we're going to get some things done. And possibly, you know, one or two of those individuals will be here in Fargo, hopefully in 2022. Yeah.
That's a good segue to a COVID update.
I don't know if we're going to go segue to a COVID update, but we will go ahead. So just to give you a little sense of where we're at here and statewide. So COVID cases, they're still at that kind of high plateau. We have 843 active cases in Cass County, a little over 2,500 in the state. Our positivity rate is remaining fairly high. Testing numbers are remaining fairly low. Especially on the weekends, they really drop off. Cass does tend to make up about 27 to 33% of the tests statewide, so there isn't a lot of testing happening anywhere in the state. Currently, we have 146 people hospitalized with COVID. You know, that goes up or down 20, but there again, it's not decreasing very rapidly at all. Hospital capacity remains really tight for staffed beds again, just with high census, and that is locally and across the state. We usually have under 5 beds and sometimes under 2 beds locally that are available either in the ICUs or regular adults. So deaths for Cass are at 281. We had 2 more today. Last week, there was 33 deaths in the state. This week, so far, there's 29. So still lots of impacts from COVID. Last week, nationally, I don't know if any of you heard the news, but we hit the milestone of reaching 800,000 deaths in the United States, which was quite somber moment. The Kaiser Foundation also released a report that estimated that 163,000 of those deaths since June likely would have been prevented with vaccination. Pfizer vaccine boosters have been approved now for 16 to 17-year-olds since we last met, as well as the Omicron variant is obviously on the horizon as well. Dr. Newman is going to present on that shortly. Just to give you an idea of our operations that are still ongoing, local vaccination traffic is beginning to slow. We're getting mainly booster traffic at this point, and then a handful of first and second doses. Our vaccination team has met with Sanford Ascension Family Healthcare to discuss our efforts going forward, as most of those agencies have transitioned their operations into their normal activities. Family Healthcare is doing some mobile missions, such as at the schools, to get vaccinations out. At the end of December, Fargo Cass is going to transition our mass vaccination clinics back into our normal immunization program, which appointments would then be needed. And everybody really felt comfortable with this. A lot of the larger health systems have the walk-in clinics where there is accessibility in after hours timeframes, there's weekend timeframes, and so we feel that it's a good time for us to kind of stop the mass vaccination operations at this time, and then just have it back into our normal clinic. And this will then help us also get some staff back to some of our normal operations so they can start focusing again on some of our routine programming. Our testing site remains very busy. We continue to extend that lease of the building on a month-by-month basis. Of course, the intent when we started that testing site was to fill the gap of travelers, was kind of how we were told when we got into that business. However, that's kind of turned into us being the main place within the city pretty much for general population testing. So the challenge for us with this is sustainability and staffing. So we will kind of continue to evaluate and monitor that for any changes needed going forward, and see if there's ever a good point for us to start kind of backing away from that as well, if there's other opportunities. We have continued, us along with the health systems, North Dakota Department of Health, continue to encourage vaccination and boosters through our messaging. But as most of you know, these are really difficult times for any kind of call to action. We are having a little bit of difficulty, I think, with the general public being really desensitized to COVID and the new variants. And so we'll just have to kind of see, because we've been in this heightened state for a couple of years, if there is really anything that's going to make people respond. I guess we don't really know that at this point. But despite that, we'll continue to remain consistent in the hopes that we may impact someone who hears. Tons of misinformation. Again, that's kind of our nemesis. Everything on social media, I think, is misinformation at this point for the most part. So we just try to keep providing that consistent message. So we will continue with those mitigation strategies of the vaccination for, all that are eligible. Booster doses are going to be really important, as you'll hear when Dr. Newman speaks. Masking recommendations for those indoor crowded spaces, and then testing early for exposures so we can help slow transmission and lessen that human impact from COVID. So with that, I will turn it over to Dr. Newman to talk about Omicron.
Okay. Turn it up, Justin. I don't usually go from this office. I don't know how. I have it full blast.
Oh yeah, it's not picking up the mic that well.
Okay.
It's not bad.
It's not bad.
I can get close and talk louder. Is that okay?
Yep.
Sorry. Well, thank you. And thank you. I also want to extend a warm welcome to Dr. Hogan. It's so nice to have you here.
Thank you.
We look forward to the work you're going to do in our community, in our city. And please know at Public Health, we're excited to work with you anytime.
Thank you.
Okay. Do I have some slides?
Yes, they're going to run those from City Hall.
Oh, wow. I didn't know it did that. That's fancy, guys. Okay. Next slide, please. And if I need to speak louder, just give me a little reminder. I was asked today just to provide a brief update. I'm sure everyone's been hearing a lot about this potential new variant coming and what that might look like. I'll also touch on a couple of other just brief updates happening. So I'll preface this talk by saying information is changing extremely rapidly, and we are literally trying to get this information from preprint studies and daily information on the ground in South Africa and now in the UK. So everyone is doing the best they can to assemble information, but some of this has changed even from when I put these slides together. So I'll do my best here. Okay, so SARS-CoV-2, or the WHO, I should say, has declared the SARS-CoV-2 variant B11529, or Omicron, a variant of concern. So this is more severe than a variant of interest, but it's less severe than a variant of high consequence. This new variant, the B11529, was first reported in South Africa in November. Since then, in a little over a month, we've seen Omicron cases be reported in numerous countries in the world. It's likely now in almost every country. And it is in as many as 35, that's actually updated, US states. So 5 more since I did these slides. We can assume it's in all 50 states. We have not had an official Omicron, at least as of this morning, case reported in North Dakota. I think it's safe to assume it's here, given our neighboring state, Minnesota, was the second state to report. This variant is spreading faster than any previous variant that we've seen throughout the pandemic. Omicron now accounts for more than 90% of all new infections in South Africa. And it is predicted to overcome the Delta variant as our primary infecting variant in the US in a few short weeks. US Omicron cases went up 7-fold in 1 week. From last week to this week. They now account for 2.9% of the cases we're diagnosing, and that's up from 0.4% the previous week. So really rapid increases we have not really seen before. Federal health officials are predicting Omicron could surge in the United States as early as next month in January. Next slide. So there's now scientific evidence to say that Omicron is more transmissible than previous variants. And this is thought to be due to key changes on the coronavirus spike protein. So the Omicron variant has over 50 total mutations, but it has specifically 32 mutations on the spike protein itself. The Delta variant had 9 for comparison. So it's a little unclear to scientists and epidemiologists what these mutations could mean, but given there's such a high number of them, there's 3 things we really care about. Number 1, increased transmissibility, which so far it's looking like that will be the case. Number 2, increased severity. So are we more likely to see hospitalizations, death, more morbidity and mortality? That is yet to be seen. And number 3, enhanced, capability of this new virus to escape our vaccines or even escape our infection-induced immunity. Again, these will kind of be lagging indicators, so that is yet to be seen. Preliminary findings suggest that Omicron at this point appears to be much more transmissible, but not cause severe disease. As we know, hospitalizations and deaths are lagging indicators, and we are just approaching this week that 3 to 4 week mark where we'll start to get that information. So people are watching very, very carefully, but we are still awaiting this data. Omicron does seem to be driving a new wave of infections in South Africa, where in one region, a lot of people are watching the Gauteng region. This is where Johannesburg is. It's a big, large epicenter. Test positivity rates have increased from 1% to 30% in just 7 days' time. So again, this is just spreading faster and quicker than we've seen before. Disease modeling experts have estimated that the B11529 variant could be 500% more transmissible than the original Wuhan virus. For comparison, Delta was thought to be 70% more. Am I okay on time? Okay, next slide. I can skip this next if you want. You'll hear a lot of things being talked about, so I thought I would just refresh us if you're interested. I'll try and go fast, but there's 2 things we talk about when we talk about transmissibility in epidemiology. One is the R0, or the reproductive number, and one is RT, or known as the effective transmissibility. And these are 2 different things, so I just wanted to clarify for you guys a little bit. R0 is the spread of disease if nothing was stopping it. So we often talk about R0 at the very beginning of a pandemic. So if you have no vaccine, you have no existing immunity, you have no screening or quarantine, there's no mitigation efforts happening at all. R0 is the average number of people infected from 1 case. So you can see the little chart here. For example, if the blue guy has Ebola, that is thought to have an R0 of 2. So he would infect every 2 people, and then those people will go on to infect 2 people, and so on. The original SARS virus was thought to have an R0 of around 4. The Delta variant was thought to have an R0 of around 6. So RT, which is really what you'll hear talked about now, is a little bit different. So this is the actual transmission rate now on the ground right now. This takes into consideration things that slow transmission, like our existing immunity, our human behaviors, our masking, our hand, all of these things. So again, R0 is the initial reproduction number of the virus at the beginning. RT is the reproduction number at any particular point in time during a pandemic. But they're not apples to apples. So you might see comparisons in the media that are incorrect. But an RT of less than 1 means the infection is not spreading. That's where we want to be. And modeling research, again, preprint coming out of South Africa, they were estimating that the RT was 0.8 at the tail end of Delta, which was good. South Africa was in a good spot. And now it is closer to 3, some experts predicting 4 during Omicron. So with this high level of transmissibility, they're seeing cases double every 3 days in South Africa. Okay, questions about that? So no, it's fine. Yeah, next slide. Thank you. So this is just a figure that, again, comparing contagiousness. And really, this just shows transmissibility on the horizontal axis, and then our antibody effectiveness on the vertical axis. And this takes into account all of our previous variants. The higher in either direction, the worse. Omicron, really, to know where Omicron is on this chart is a complex and scientific guess at this point, but we're hoping to know that information soon. Next slide, please. Of good news, Omicron can be detected on a PCR test. So previously, our swabs needed to be sent to certain labs for genomic sequencing, and this took time and a delay, for example, in knowing how much of the Delta variant we had. Specifically, Omicron variant will light up 2 channels on the PCR instead of a 3, so it's a very specific finding. And this can allow us to track the variant cases much quicker and easier around the world. Studies are underway right now and being conducted to see if our rapid antigen tests will be able to make this determination. There is some promising preliminary data that we maybe even could detect Omicron from a rapid antigen as well. Next slide. So a few things that I am watching, and then probably many others in the healthcare world that are of concern. Again, it's early, we need more data. But these are 2 things that have gotten people's attention. One is the rate of reinfections they are seeing in South Africa. I'll talk a little more about that. And 2 is the rate of younger pediatric cases, specifically children under 5. So many people are watching this very carefully. So the WHO is reporting preliminary evidence suggesting that there's an increased risk of reinfection with this variant. Information is limited, but again, the infection-induced immunity may not work well against this variant. This was somewhat true with the Delta variant as well. We know that infection-based immunity or natural immunity with Delta, these patients were 5 times more likely to become reinfected than were those that were vaccinated. There is evidence to show that the rate of reinfection with Omicron is looking like 3 to maybe 8 times greater than it was with Delta. And there's definitely data in both UK and South Africa showing a higher percentage of unvaccinated than vaccinated patients needing to be hospitalized with Omicron. And then this was of my interest as a pediatrician. South Africa has presented the age distribution, that's what's shown on this chart here, of their hospitalized patients. And it is apparent that younger people are going into the hospital at a higher rate during this wave. The Omicron wave is by the orange bars, compared to the Delta wave, which is the blue bars. This pattern is specifically apparent for kids less than 5 years old. South Africa is sort of actively investigating why this may be. There's a couple of circulating theories, but it's definitely something to watch very carefully as it comes to our area. Next slide. Again, this is preliminary, non-peer-reviewed, not preprint data, but it's very interesting. There are some studies to show that the 2 doses of the Pfizer vaccine is going to provide about a 33, to be exact, % protection against Omicron infection. To note, and encouragingly, it does still provide 70% protection against hospitalization, but much less efficacy than we were used to with Delta. However, getting a booster or getting a third dose increases that efficacy to 70 to 80% for protection of infection. So as Desi said, our booster shots are going to be really important and our best sort of tool for combating this. I think all of this considered, we can really expect, increase in breakthrough cases, especially in those who've only had 2 doses. But I do believe the boosters will likely continue to reduce our viral transmission and specifically reduce people becoming very, very sick. As of now, U.S. health officials have indicated not leaning toward making a vaccine specifically for Omicron, believing that the current vaccines with boosters will be able to withstand this variant. Again, it's early and that could change. Next slide. I'll briefly just review our vaccine dates, updates. Desi went over our case rates. So U.S. total, we're not doing too bad. 1 dose, 72%, fully vaccinated, 61%. I went ahead and included the 5 to 11-year-olds because that's our newest population being vaccinated. And you can see nationwide, 1 dose, 17%, fully vaccinated, 4%. So not great. In North Dakota, we're sitting at about that 50% mark. We've been there for a while. For our 5 to 11-year-olds, we're at about 12% statewide of having 1 dose. We're doing much better in Cass County. Our 1 dose total is 63%, 2 doses, 59%. But look at our 5 to 11-year-olds at 22%. We're definitely the highest, I think, or one of the highest in the state. And 11% of 5 to 11-year-olds have had both doses. Next slide. Just a brief note about boosters. On December 9th last week, the FDA authorized emergency use authorization for the Pfizer COVID-19 boosters for 16 to 17-year-olds. So this means several million teenagers in our country are now eligible to get that 3rd dose. The FDA is authorized and CDC recommends now a single booster dose for everyone over the age of 18. There used to be kind of those stratification things. Now they just say anyone should. So that is people who got Pfizer and Moderna, that's 6 months after both doses. And if you got J&J, it's 2 months after that single dose. And then also to note, just last night, Pfizer sought FDA full approval for their vaccines for 12 to 15-year-olds. That's expected to be looked at and voted on probably in the next few weeks. And then just to point out, as when I made this, 27% of Americans have been boosted, and 33% or about 1/3 of North Dakotans, which is great news. Next slide, please. A brief note about monoclonal antibodies, and then I'll stop talking here. The FDA has expanded emergency use authorization for monoclonal antibodies to include young children under the age of 12. So the 2 listed here, which I won't even attempt. Oh, I just lost my screen. I was going to say I won't even attempt to say. They are currently being used for high-risk people as post-exposure prophylaxis, or in certain groups who have tested positive for SARS-CoV-2. So children under the age of 1, anyone as an infant is considered high risk automatically. And these can be given even down to newborn age. And then those that are over the age of 1 would qualify for the things listed here. Kind of similar high risk things to what we saw in adults: chronic illness, obesity, if they're medically reliable on some sort of technology like a G-tube or a trach, pregnancy for adolescents, things like that. And just, as with all ages, we're excited this is available for kids, but this therapeutic option should not be a substitute for vaccination. Next slide. And one other note about oral antivirals. This is some exciting news coming down the pipe. Pfizer has sought FDA authorization for its oral antiviral called Paxlovid. This is a combination of 2 protease inhibitors, and its initial data is looking much more promising than molnupiravir, which was Merck's oral antiviral released last month or approved in October. So Pfizer is claiming with its data that if this oral is given within 3 days of the onset of symptoms, it can reduce hospitalization by almost 90%. That's really remarkable. And even if given within 5 days, it still reduces it close to 88%. Again, Merck's initial trial data had suggested 50% reduction in hospitalizations with its oral. On the ground, that really ended up being 30%. So these numbers looking a little better. I'm guessing the FDA will announce decisions on this in the next week or two. Next slide. So to end, just I've told you what we do know about Omicron. I'm happy to answer any questions, things we still don't know, and questions we all still have. Will this be more or less transmissible? It's looking like it will be more. Severity is still kind of a big question mark for people. How are older people going to fare with this, people in nursing homes, or how are people who don't have any baseline immunity, the unvaccinated, and really just in our country or in our state, do we have an adequate level of herd immunity or population level immunity to keep our hospitals from flooding? I think that these are still things that we just don't know. And then my final slide is what can we do in the meantime? Next slide, please. It's just all the things Desi said earlier, all the things we're used to. It's not progressing, but anyway, yes, there you go. These are the things we are doing and things that we can do. So I think these things will continue to help us protect against Omicron, protect against severe illness and death from COVID-19. The most important thing we can all probably do is encourage people in our immediate circle to be boosted. Thank you.
Thanks, Dr. Newman. I know, Robin, you had some questions for Desi. Do you want to go?
Sure. I have a question for Desi and Dr. Hogan. Desi, I got my school board hat on right now. Tell me about the mobile vaccination units. Are they only at the secondary schools? And how are parents' permissions verified? Because we're board members are hearing a lot about that.
So, Robin, I might have Suzanne jump in with this with me as well. I know we did a contract with Family Healthcare, so we aren't actually handling the mobile vaccine clinics. So we had gotten some grant funding for that, and because we didn't have the resources to do the staffing for that, they were willing to take that on. So I don't have any, I assume it's very similar to what, we used to go to the schools years ago and do vaccine clinics all the time. And we would have parents sign consents and, depending on the age group, many parents came to be with their child during vaccination. Those that weren't, they would send the consent in, and it's never been an issue for us in the past when we used to do it. I can't imagine that their operations are much different. The parent has to sign and, give that permission to do it. There's no one, it's a totally voluntary thing. Everybody, if they want to have their child done there, they can. If they don't, there's no pressure to do anything. It's providing access to those who may not be able to take off during the week to get their child somewhere to get vaccinated. But if there's any specifics on Family Healthcare's process, I would need to defer to them to probably answer, what exactly their process is. But that's just what we used to do when we would have vaccine operations.
Thanks, Desi. Yeah, I would like a little bit more information on that, just due to parent questions. Dr. Hogan, I run 16 Boys and Girls Clubs here in town, and I'm also the representative for the Fargo School District. 2 questions. Are you working at all with Dr. Usselman from Fargo Public Schools, and have you met? And then secondly, are you only doing work within the city departments, or are you doing any work out in the community?
It's going to be both. Everything is going to be totally universal. I'm working with stakeholders on the outside and internally. It's just to the premises right now, being that it's just me, is only so much that I can do, within a certain scale. But in 2022, yes, everything is going to be done internally, externally, stakeholders, you call it. Now, in regards to, is that Tamara?
Tamara Busselman?
Yeah, Tamara. Yes, we have. I've been going to various meetings that she's been inviting me to, in regards to some kind of a teachers program that they're trying to institute. So with that being said, I'm learning about the educational attitudes here in North Dakota, and I have given my, whatever she needs from me, it's good. It's all good. I'm willing to help as much as possible.
Thank you.
You're very welcome.
Okay.
I was just going to mention too, Suzanne had sent me an email during this. She had just gotten the latest booster numbers for Cass, and we are sitting at 37.7% of those that have been vaccinated have their boosters. So we still have quite a few in our area that need that booster shot. So.
And Desi, are you still doing the booster clinics on Saturdays too?
Nope. We so that for the next, today is our last one for the Friday, okay. And then the next 2 weeks we have Tuesdays clinics. But then, like I said, it sounded like Sanford walk-ins have availability on the Saturdays, and then the after hours, and then we would continue with our Tuesdays, and then we'll kind of just see where we go from there. I think. The vaccination group also made a handout of like resources where vaccine is available, and there really are many, many opportunities within the community. So I think people will find it if they need it, and we can help that too. If they have a call, if they want to call, we can certainly give them those resources as well.
Sorry, you had mentioned that. Any other questions?
Chelsea, if I could add.
I have a question. I'm sorry.
No, go ahead.
Okay. This is Charlene Nelson. I have a couple questions. Going back to the vaccination clinics at the Fargo Public Schools, you said that this was paid for by a grant. Is that correct? Did I understand that right?
It's the immunization grant that came through the state health department, and so it's to increase immunization rates in general, and to also increase COVID immunization access, and for people that may have difficulty with access, that maybe don't have the resources to get somewhere to get there. That's what that grant supports.
Okay, but that's a grant that came to Fargo Public Health, and then you contracted out with Family Health Care. Did I understand that correctly? Yes. Okay. And then back to your report on the different variants. In the last meeting, you said that you'd reported that all of the random tests that were being sent to Bismarck for further testing were coming back as the Delta variant. Is that still the case now? Or are we seeing, we don't have any Omicron. So are we seeing all of the
Yes, that is the case. And here in North Dakota, definitely. Nationwide, even again, this is changing rapidly. I would say greater than 96% of the cases in the United States are still Delta. But based on what we've seen in other countries now, that is expected that Omicron will overcome that in the coming weeks very, very quickly. And we've already seen a 7-fold rise in Omicron cases just last week here in the United States.
Okay. All right. Thank you.
Yes.
Okay. Arlette?
Yeah. So Chelsea, I just have a quick question in regards to the boosters. Desi, is the state health department doing anything to communicate directly with those of us that have gotten the first 2 vaccines? I think the information about boosters has been a little bit confusing. About who it's, qualified to get it. Do you know if there's been any communication coming out to all of those of us that have been vaccinated?
I don't think they have sent out any, they did that early on when it was, people had their first dose or when they would be due for a dose. I don't think they have done that with boosters. We can certainly inquire about that. If that would be helpful, we could certainly ask.
Seems like that would be a wise thing to do, probably.
Yeah, I think especially with the, more broad use of the booster and not having all those caveats, it seems appropriate, especially if it's going to be more effective against the new variant.
I don't know. This is Lynn. I don't know if we saw in the data, do we have the numbers on the number of North Dakotans that have gotten the second vaccine that have yet to be boosted? Do we know those numbers?
Yeah,
that
was
the 37.
Yeah, that's the 37.7%.
Okay.
Yeah.
Okay.
Oh,
Thank
no,
you.
that's who's been boosted, right?
They've been boosted, yes. So there's the,
I think you're asking Lynn, who's just had 2 doses.
Yeah, the ones that are in, but the ones that have gotten the 2 doses but haven't been boosted yet.
Yeah.
For North Dakota total, we have that 50% have had 2 doses.
And not boosted. Okay. Sounds good. So, yep, I agree. A lot of opportunity there to get that information, and perhaps from a state level.
Mm-hmm. Okay. Other questions? Okay. All right. So next on the agenda was approval of the schedule for 2022. I think I just received it, Lori. I don't know if everybody's received it. We talked about it being on Fridays every other month and of what has been occurring so far, but I don't know if we need to.
Yeah, and Lori, I think Jim, if she didn't send it out, it will be sent out. But the only one that's not a Friday is the May meeting, which is our budget meeting. So that is on a Thursday, typically. So otherwise, our next meeting after this would be February 18th, and then we, go the every 2 months after that. So when you get the schedule, look at it. If there's any conflicts, please let us know. We're kind of still thinking of continuing the virtual format as long as we remain in this kind of, substantial to high transmission for COVID. It's kind of, it just seems more prudent to do that. So that's kind of our plan for right now. We do have opportunities, if someone wants to do public comment, they are, because of the system we're using for this meeting, the PEXIC, it's like if someone wants to do public comment, they would have to go down to the city commission chambers, but they are able to do that and be there for public comment if they would like to join in. We can't have both virtual formats going at the same time, but certainly are welcome to go down to City Hall if they would like to. But like I said, that's the schedule. If anybody has any conflicts, please let us know. I think we tried to avoid holidays. We did that last year, so I'm hoping we did better this year. But yeah.
Do we need formal approval on the schedule at all, or is it just take a look and let us know?
Yeah, I don't think we do.
Okay. Okay. And it doesn't sound like there's anybody at the City Commission chambers for public comment.
Yeah, he said that at 12:58 there wasn't anyone there, so.
Okay. Well, as Desi mentioned, our next meeting's February 18th. And so hope that everybody has happy holiday and stay safe and stay healthy. All right. Thanks, everyone.
Thank you.
Happy holidays.